Thank you. The third agenda is opening speech. The speech will be delivered by Director of Cendekia Utama Kudus Health Technology Institute, Mr. Ilham Setiabudi, Eskep MKes. We are honored to have him here with us today. Mr. Ilham Setiabudi, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh, Bapak.
Good morning. Best wishes to all of us. The honorable speakers, Dr. Caroline Pelan, Dr. Nur Azizah Zakaria, Professor Manit Sitau, Bachelor Pharmacy, graduating in Pharmacotherapy PGUP, the entire academic community of Ethikes Cendekia Utama Kudus, and all the participants. Today's agenda is one of our university effort to support our vision to become an excellent and internationally competitive university. Ethikes Cendekia Utama Kudus is one of the institutions in Central Java that was founded 20 years ago. It has 3 departments: Andus, Department of Nurses, Department of Pharmacy, and Department of Public Health. To realize our university vision, we are organized this international conference. Nowadays, non-communicable diseases are diseases caused by a lifestyle that has a major impact on the quality of patient life and their family. In palliative condition, to complain that often arise is discomfort. Patient often feel uncomfortable with their condition. Therefore, the management and approach to pain in palliative patient need to be studied from various experts. Welcome to the speakers, and I want to say thanks for guiding us through this conference. We are waiting for the sharing of knowledge from the speakers in this activity. For the information, the participants of this international conference and the academic community, professional health workers like nurse, pharmacists, and public health. We also wish to thank all the communities who have organized this international conference. We hope that this conference has a beneficial impact on the participant. That's all for my speak. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Warahmatullahi wabarakatuh.
Thank you. Ladies and gentlemen, for the fourth agenda, we will have a photo session. To all distinguished guests, honorable speakers, and esteemed delegates are requested to be prepared and smile for camera. Let's begin from the first slide. Please look at the camera and give your best smile. Take the picture in 1, 2, 3. Next, the second slide. Second slide, please give your best smile. 1, 2, 3. Next, third slide. 1, 2, 3. And fourth, 1, 2, 3. And then the next slide. 1, 2, 3. Please turn on your camera and give your best smile. 1, 2, 3. Next, 7. 1, 2, 3. Next slide. 1, 2, 3. Thank you. Now we have reached the main part of the event, which consists of the material presentation and panel discussion. The moderator will take over the session from this point. Before that, I would like to introduce the moderator of today's conference. She is Mrs. Reni Wulan Aprilyasari, as a lecturer of Medical Surgical Nursing Department, Cendekia Utama Kudus. She was graduated from Cendekia Utama Kudus in 2010, and she got her Master of Science in Nursing from Indonesia University in 2013. And she got her PhD from School of Nursing, Taipei Medical University in 2022. She expert in chronic disease, stroke, secondary data analysis, and meta-analysis. By her expertise, she experiencing as a lecturer in Cendekia Utama Kudus from 2011 until present, and being postdoctoral researcher in Biobehavioral Laboratory, Taipei Medical University, Taiwan, 2022 until present. Please welcome Mrs. Wulan Aprilyasari. Time is yours.
Okay, thank you very much to our beautiful master of ceremony for the introduction. Good morning, everyone. Good morning, our distinguished guests, esteemed speakers, dear participants. My name is Reni, and I am honored to serve as moderator for this prestigious event from this conference. So our theme this year focus on the crucial aspect of pain management within the realm of the palliative care. And this plenary session, we will learn into various approaches to pain management, exploring innovative technique and best practices. And also, we privileged to have with us 3 distinguished speakers. The first one is Professor Dr. Manit Situ from Kokang University, Thailand. The second one is Professor Dr. Caroline Pillen from Flinders University, Australia. And the third one is Dr. Azizan Zakaria from University Kebangsaan Malaysia. And for the information, each speaker will have 30 minutes to present the topic, followed by 25 minutes panel discussion. And I also remind the participants, we encourage you to write down any question you have during the presentation, and we will address them during the Q&A season. Okay, let us begin because Professor Manit already with us. I would like to introduce our first speaker. The first speaker is Professor Dr. Manit Situ, Science Kokang University. Anyone can help me to share Professor Manit curriculum vitae? Thank you. Professor Manit have earned board certified oncology pharmacist from Board of Pharmacy Specialists from USA since 2011. Professor Manit also participated in several international events in oncology, and his main interest is in cancer treatment. Now, he will share with us her perspective about pain management approach from pharmacy view. Please join me in welcoming Professor Manit Setio. Professor Manit Setio,
Good
are you
morning.
ready? Morning,
Yes,
Professor. Okay,
yes.
Professor Manit Setio, now is the time is yours, around 30 minutes. Please,
Thank you.
anyone help me to share her Professor Manit presentation. Thank you so much, Professor. Now the time is
Yeah.
yours.
Yes. Yeah. Thank you for introduction. And thank you, Cendekia International Conference on Health and Technology for invitation me to share my experience for the pain management in the palliative care. I will move forward with my slide presentation. I have about 30 minutes for my talk today. And again, I'm very happy to be here today and share anything with all of you. So the outline of my talk today, because that I have just a limited time for 30 minutes, today I will focus on only for the pain management in the somatic pain. But my slide will cover for the neuropathic pain is where I will left over for you if you want to just reading more for the neuropathic pain. First thing, I will just start with the cases. This is the real case that I have. I have the one patient who have the lung cancer with the metastatics, and the pain score is quite very high, so 9 above 10. So the thing is that what medication that we need to provide for this patient to control the pain of these patients. And another thing is that we start the pain control with the morphine, 2 milligram intravenous every 4 hours. And then after that, the patient can comfortable with this medication. But after treatment, we will send the patient back home. So we need to change the medication to be the oral medication. So how we can change the medication from the IV morphine to the oral morphine. This is the thing that we face for every times in our patient who have the cancer, and also for the palliative care. We treat the patient with the IV medication, but we need to send the patient back home to get the medication with the oral medication. So before my talk, I will just introduce a little bit about what the importance of the pain control in the palliative care. This is the one study is focused of the patient who are in the palliative care, and we just explore the symptoms that the patient will have. You will see that for the pain symptoms, the patient have the symptom for the all kind of the disease. For this cancer, COPD, heart failure, instead renal failure, dementia, or for all kind of the disease that we have the pain in the background that they need the medication for the treatments. Another study, this study is in 2006. This is the systematic review. They pull out the data from many of the studies, and they analyze and show that pain still be one of the symptoms that which is the very important, and many patients have during the palliative care. And if we focus on the cancer with pain, the incidence is quite very high, from 30% to 90%, depend on the study. So that means I can estimate at least half of the patient, 50% of the patient have the pain symptom during the palliative care. So that's why pain control is very important issue that we need to focus on if we want to do the palliative care for many kind of the disease. So for the cancer, for the pain symptoms, if we separate the cancer patient for the newly diagnosed, we will have the pain symptoms around 30%. But if the disease is progress on for the advanced disease, you will face the pain symptoms about 80%. And at the end of life of the patient before death, the pain will be the majority of the symptom of the patients. Is more than 80% of the patient have pain symptoms. So the barrier for management of the pain symptom, we can classify to the three factor that will have the problem when we do the pain control for the patients. The first problem is from the patient. Some patients some patients don't want to use morphine because they think that if they use the morphine, they will get addiction and they will have some side effects from morphine. They don't want to use it. This is one barrier that we face during all the time that we do the pain control for the patients. The second factor is from the healthcare provider. The same thing, some healthcare provider not comfortable to use the strong opioids such as the morphine or methadone for the long-term treatments because they don't want the patient get addiction or get the side effects for using the strong opioid. And last but not least, the last factor is the system. Because some healthcare system they not provide sufficient of the opioid because sometimes we face this problem of lack of the opioid in our hospital, and we need to change the patient with another opioid to make sure the patient can get control because we don't have that for that time. This is the three factor we all the time face with the patient who during the time that we do the pain management. So for my talk today, I will focus on the pharmacology of the pain control. So before the pharmacologic session, I will just let you know a little bit about the pain. What is pain? This is a very important that we need to know because that everyone have pain, but we cannot explain what is the pain. So we know we have faced we have the experience with the pain symptom, but we cannot explain what is the pain. So there are many international organizations do the definition of the pain, but it's not some definition is not explained well for the pain. But the thing I need to let you know that because the pain is based on the patient experience, the first thing that we need to for the pain control, we need to concern is you need to trust on the patient because no one can explain the pain better than the patient themselves. The first issue to do the pain control, trust on the patient with the pain. And if you know that the patient have pain symptoms, the thing that we need to assess is the classify of the pain. Pain can be classified into the two majority groups. The first one is the nociceptive pain. This type of the pain is the pain occurred by the organ damage. So for this type of the pain, the patient can localize the area of pain. And the second type of pain is the neuropathic pain. This type of pain is occurred from the damage of the neuron. And the patient will explain you about the different symptoms like itching, or have the pain radiation, or have the sparking pain. This is a very unique type of the pain. So after we know that what type of the pain of the patient have, we can do more for the pharmacologic management, because that the drug that we use for the nociceptive and neuropathic pain is quite different. For the nociceptive pain, you can use the opioid, for the weak opioid or strong opioid. But for the neuropathic pain, the medication the pain cannot control well with the opioid. You need to use another drug. For example, the gabapentin or the tricyclic antidepressant for control the neuropathic pain. Okay, after we can classify the pain type, we need to focus on the symptom of the patient. We can do, I'll give you an example of the for the mnemonic that we do for the classifier of the pain. We use the PQRST mnemonic. The P stands for the provocative factor. What is the precipitation or the palliative factor of the patient? The Q stands for the quality of pain. You need to classify between the neuropathic pain or nociceptive pain. R is the regions, the location of the pain. S the severity, how severe are the pain symptom of the patient? Is it mild, moderate, or severe pain? And T stands for the timing. When of the symptom occur? Is the symptom have all the times or just only some time of the day? So to assess the severity of pain, we have many tools for the assessment of the pain symptoms. We have the visual analog scale, numerical rating scale. We have the phase scale, or sometimes we need to use another assessment we call the flag scale. I don't need to just focus. For my talk today, I have only 30 minutes. I will not cover for all of them. So I will just show you how we can assess the pain symptom. For the visual analog scale, it's like this. So the patient need to assess the pain themselves. For the numerical scale, we have the number to make the patient more comfortable to assess their pain symptoms. The phase scale, this is the patient need to assess themselves by the phases that happen in the assessment tools. And the flag scale, this is the thing that when the time the patient don't understand anything, they cannot understand the visual analog scale, they not understand the numerical rating scale or phase scale. We do the flag scale. This is the flag scale the assessor need to do themselves, not for the patient do assessment. After we get assessment of the pain symptoms, we will classify them for the mild, moderate, or the severe symptoms. For the mild pain score is around 1 to 3. The moderate pain, the score is 4 to 6. And if the pain score more than at least 7, it's classified as severe pain. After we know the pain symptom of the patient, we can do a management with the medication for the patient. For the mild pain, we can use the non-opioid for the NSAID or the paracetamol. For the moderate pain, we give them the weak opioid. And for the severe pain, we provide the patient with the strong opioid. For mild pain, the medication I already mentioned is the non-opioid analgesics. It's including the acetaminophen or paracetamol. It can be used the NSAIDs or the COX-2 inhibitors. This group of the medication is very well to control the mild pain symptoms, but they have the effect we call the ceiling effect. The ceiling effect is stand for if the effect that if you increase the dose of this group of the drugs, it can increase the efficacy until the maximum dose. But after achieve the maximum dose of the drug, and you still go on to increase the dose, it cannot have more effects to control the pain anymore. But it will have the severe toxicity for the patients. This means this group of the drug have maximum dose you need to consider. So another issue for the limitation of this drug is the adverse events. The paracetamol or the acetaminophen, you really know that this drug have the hepatotoxicities. So you cannot use with a very high dose for a long time. And in specific group of the patient who have the liver symptoms or liver toxicity before, you need to very carefully use acetaminophen in this group of the patients. For the NSAID and the COX-2 inhibitors, the problem is this group of the drugs have the renal toxicities. Changing from NSAIDs to COX-2 inhibitor not decrease the toxicity or not decrease the renal toxicity, it still be the same between NSAID and COX-2. Be careful to use in the patient who have the renal symptom or the kidney impairment. Another issue is the NSAID have the antiplatelet activities, and it will have the bleedings. And also the NSAID and COX-2 have the GI toxicities. Be careful to use this drug in the patient who have the GI symptoms, such as the peptic ulcer or the another of the gastritis that need to be concerned to use. For the moderate pain, we treat the patient with the weak opioid. The weak opioid consists of the codeine, hydrocodone, and the tramadol. The same things, the weak opioid also have the ceiling effects. That means this drug group have the maximum dose to use. Increase the dose more than the max dose have the side effects, not increase the efficacy of the treatment. Another issue of the limitation of this drug is the adverse events. So the codeine and tramadol has a problem of the nausea, vomiting, and also have the sedation effects when we use with a very high dose. And this group of the drug also have the drug-drug interaction you need to consider. For the first of the drug in this group is codeine. Most of the time we use the codeine for the cough reliever, but you know that codeine is the product of the morphine, and it will change from codeine to morphine by cytochrome P450 subtype 2D6. 2D6 can convert codeine to morphine and have the pain control effect. The problem, if the patient use the 2D6 inhibitors, when we provide the patient with codeine for the pain control, it cannot convert the codeine to morphine because the drug, the patient use another drug, is the 2D6 inhibitors. So before we give the patient with the codeine, we need to assess the medication that patient already have. If there are some drugs that are 2D6 inhibitors, we need to change the codeine to another drugs. And what is the drug that is the strong 2D6 inhibitors? Most of the time is the antipsychotics. It's the paroxetine, fluoxetine, bupropion. This is the 2D6 strong inhibitors. So if we know that the patient already used these drugs, and we want to give the patient with some weak opioid, we need to change. We don't use the codeine for this group of the patient. And the maximum dose of codeine is 360 milligrams per day. The tramadol is another of the weak opioid. This drug have the two effects. The first effect of the drugs, this is a mu receptor agonist. It can control the somatic or nociceptive pain. And the tramadol also have the serotonin and norepinephrine reuptake inhibitors. For this effect, make the tramadol can control the neuropathic pain too. So the tramadols, because that there are the serotonin reuptake inhibitors effects, this is called the problem of this drug too. When the patient get the drugs for the antidepressant, which have the serotonin reuptake inhibitor effects. For example, the tricyclic antidepressant or the SSRI, such as the fluoxetine. This will have the interaction with the tramadol and make the patient have the serotonin syndromes. So be careful to use both group of the drug together with the tramadols. The maximum dose of the tramadol is 400 milligrams per day. But if the patient have poor renal function, the creatinine clearance less than 30, the maximum dose is only 200 per day. Okay. For the severe pain, the pain score 7 to 10. We need to we will use the strong opioid for this patient. And we have many types of the strong opioid from now. We have prototype of the morphine. We also have the oxycodone, fentanyl, methadone. This strong opioid is very effective to control the pain of the patient. The good thing for the strong opioid is the strong opioid doesn't have any ceiling effects. That means they don't have the maximum dose. You can increase the dose until the patient have the pain control. So the limitation of this drug, the only limitation of this drug is the side effects that we need to concern. If we give them a lot of the a very high dose, it will increase the side effects of the patient. Morphine is the prototype of the strong opioid for a long time. And we have many subtypes of the morphine. We can classify the morphine into the immediate, the immediate release or immediate effects or the sustained release. For the immediate release or immediate effects, we have the morphine IV. We also have the morphine immediate release for the oral or morphine suspension or morphine syrups. This immediate effect or immediate release can relieve the pain very fast. For IV, it just take only not more than 30 minutes. And for oral medication, it can relieve the pain only not more than 1 hour. But the problem of the immediate release is have the rapid onset, but it's very short half-life. That means after you use this drug for the immediate release morphine, it can be in your body or it can affect only 2 to 4 hours, and then it's gone. And you need to provide them another dose of the morphine. So the second type of the morphine is the sustained release or the extended release morphine. We have the oral medications such as the MST or the carpinose. This group of drugs have the long effects. For the MST, it can have effect 8 to 12 hours. And for the carpinose, the effect can be 12 to 24 hours. That means if patients get the MST, you can provide them only 2 to 3 times a day. And for carpinose, you can give them 1 time a day. And the thing you need to think about for when you use the extended release or the sustained release morphine is that when the patient have the nasogastric tube, if they cannot get swallow the medication themselves, and if you need to provide the sustained release or extended release for this group of the patient, MST cannot be crushed anymore. You cannot break this drug. If you break this drug, it will lose effect of the extended release. So if the patient have the nasogastric tube, most of the time we provide them the carpinose. we can just open the capsule and pour the pellet into the nasogastric tube and feed the patients, and it still have their extended release effects. And if you want to change from the morphine for the oral medication to parenteral, or change from parenteral morphine to the oral medication, they have the ratio to change. The ratio is the 1/3. That means 1 milligram parenteral equivalent to 3 milligram oral medications. So if we know that the patient get morphine, for example, 10 milligrams of the parenteral per day, it will be 30 milligram oral morphine per day. So after we know that the oral dose per day, we can choose the oral medication that's suitable for the patient. For me, if I know that the patient needs 30 milligram morphine per day orals, I will give them 10 milligram MSP every 8 hours. That will be 30 milligram per day for morphines for my patients. That's very easy if you know the ratio 1/3 for parenteral to oral medication. And we also have the conversion. We can do the convert from another strong opioid to be the morphine, or convert from morphine to another strong opioid. This is the table. We show you the ratio of your change. If you want to convert the morphine to another strong opioid, you can use this table for changing the opioid. So the second strong opioid I will let you know today is the fentanyls. Fentanyl, they have the multiple of the product that we use, but the most common that we use in palliative care, we use the transdermal patch. This patch is very extended, is the extended release of the drugs. It can have the effect for 72 hours or 3 days. And they also have the conversion of the, when we want to use the fentanyl transdermal, most of the time we convert from the morphine. And this is the table for conversion from the oral morphine or parenteral morphine to be the transdermal patch. And I think that this table also in the product of the fentanyl for the hospital. You can find these tables in the product of the fentanyl that you have in your hospitals. And the way that we use, I will just leave this slide for you. If you want to use the fentanyl patch, you need to know how to use and where to patch the patch into your bodies. It cannot place in anywhere. It cannot do the place of the fentanyl patch everywhere in your body. It has the specific area that you need to know. And the limitation of the fentanyl patch is the area you need to place the patch. They have some area that you can do. And this drug, after you put the patch into the patient body, they not have the effect. The effect will have the onset will take about 12 hours to have the effects. That means if you do the fentanyl patch to your patient for pain control, you need to give the patient some opioid for 12 hours before the fentanyl patch have effects. And fentanyl will also have another preparations. I will just let you know what another preparation, and some preparation we don't have in Thailand too. For the fentanyl, we also have the immediate release of the fentanyl we call the active or fentanyl. This is the immediate release fentanyls. And the active is like a lollipop. The patient can place it in your mouth, and it have the very effective and very short onset, 5 minutes. Okay, Fentanyl is the oral buccal transmucosa. This is like the tablet and the placed into the patient gum, and it have the effect to release the drugs. And another of the drug of the fentanyl that we have the on solid is the dissolving, and you have the nasal spray of the fentanyl too. So there are many kinds of the fentanyl that we have, not only the fentanyl patch that we are really comfortable to use in the palliative care. And for some patients they use, you need to know that, okay, this is the fentanyls, and this is the immediate release or sustained release of the fentanyls. Next one is methadone. Methadone in Thailand we not use for the pain control because we spare this drug for the patient who have the drug addict. But this drug also have the mu agonists, and they have the pain control effects. In addition to the pain control, they also for the mu agonist, this drug had an NMDA antagonist. That means methadone also have the neuropathic pain control too. And to use this drug, you can convert from the morphine dose, but the conversion factor is very different. It depends on the morphine dose that the patient gets. If the patient gets the low dose of the morphine, they will have the ratio is the 2:1. But if you provide the patient with a high dose morphine, the conversion factor is changed to 50:1. Okay, that is the oral of the strong opioid we'll cover for today. And another issue for 10 minutes I will just cover is for the side effects. Strong opioid will have many of the side effects. Most of the side effects we call the tolerable side effects. That means if you use this drug, the patient will have the symptom for the first time. And then after you use for the long time, the symptom is gone. Only one symptom, we call that intolerable side effects, is the constipation. That means if you use the opioid, constipation will be with the patient for the all times. If you increase the dose, the symptom is more severe and it's not get better. It's not tolerable. It's not tolerable side effects. For the constipation, if you provide the patient with a strong opioid, most of the time we provide the patient with the stimulant laxative or stool softener for constipation prophylaxis. You can give them the Senna or Jokuse, 2 tablets every night. And if you see that the patient not have good not have the response and patient still have the constipation, you can increase the dose of the Senna until the patient have one non-forced bowel for 1 to 2 days. That's enough for the stimulant laxative. In addition to the Senacort or Senna that we have, they also have the medication for just specific for the constipation.
386.
Because the metronidazole, this is the IV medication. This is the mu receptor antagonist. And this have only effect for the peripheral, not for the central activities. That means this drug can relieve the constipation without effects for the pain control. It's not have any effects for the to decrease the effect of the morphine in central for the pain control. They can only relieve the patient with the constipations. And nausea vomiting is the symptom is can be tolerated for the times. By the times, so you can give them the drug that is the antiemetics. For most of the time, we give them the Plasil or domperidone. This can get the patient with the better of the nausea vomiting symptoms. For the respiratory depression, or this is the symptom that very fear. because that is very, if it happens, it can make the patient get morbidity and mortalities. So we need to concern for the respiratory depression, and the drug that we provide the patient if the patient have the respiratory depression is the naloxone. The thing we need to know is how we use the naloxone. This is the way that we need to use the naloxone for the patient. The naloxone is the one ampoule is contain 0.4 milligram. We need to dilute them for 10 milliliters by normal saline and give the patient only 1 ml every 1 to 2 minutes until the symptom of respiratory depression is gone. This is the way that we give the naloxone for the chronic pain that the patient get a long time of the morphine or the strong opioid. For the dependence, that's the symptom that the patient and the physician don't want the patient to have. But you know that for the palliative care, there are only 1% or less than that the patient have the dependence of the drugs. If the patient have the pain symptom and the patient need it, you need to provide them the pain medication. You don't need to just more concerned about the dependence, because the data of many studies show that it's not the high incidence of the dependent or addiction for the morphine or the opioid.
Mr. Manit, I'm so sorry. The time maybe is around 3 minutes left. Thank you.
Okay. And last but not least is the step that we use the strong opioid for the patient. I already mentioned for the pain assessment for the symptom. You can use the PQRST mnemonic as I already mentioned before. And for the providing the medication, you need to think about the true subtype of the medication is the around the clock dose. That means the long-acting drug that can control the pain for a whole time, 24 hours. And you can need to provide the patient with the breakthrough dose of the strong opioid to make sure that sometime during the time that the patient get the extended release and the patient have the symptoms at that time, you have another drug to just suppress the pain symptom of that times. And this is the onset and duration of the drugs that we most common use for the patient who have the pain symptoms. Okay. And last but not least of my slide presentation for today, the first time I already show you about the pain, how it's important for the patient who are in the palliative care. The second thing, I will let you know that what is the pain symptom. You need to trust on the patient. And the second thing is how to assess the pain. You can use the PQRST mnemonics. And for severity assessment, we classify the pain to the mild pain, moderate pain, and severe pain, depend on the score or the pain symptom of the patient. And for the providing the medication, for mild pain, you can use the non-opioid, acetaminophen or NSAID. For moderate pain, you can give the patient with the weak opioid. And for severe pain, you can give the patient with the strong opioid. For strong opioid, I will let you know of 3 drugs. It's morphine, fentanyl, and also for the methadone. The side effects of the strong opioid, the thing you need to concern is the non-tolerable, is the constipation. You need to provide the patient with the laxative. And for the respiratory depression, you need to know how to use the naloxone for the to relieve the patient who have the respiratory depression. And this slide is the role of the multidisciplinary team if you want to do the pain control. The physician most of the time to do the diagnosis, prescribing, and monitoring efficacy. Nurses have the majority to do the medication administration for the patient. Pharmacists also support all of the things for the healthcare team. You need to support the information of the drug for the physicians. You need to provide medication, follow up the side effects, and also do the medication counseling for the patient to make sure the patient have the good pain control. That's all the thing that I will cover for 30 minutes. Thank you for your attention.
Thank you very much, Professor Manisetio, for the inspiring presentations. And I just remind the participant, especially from the pharmacy department, please save your question for the Q&A session because we will going to learn from our next speaker. So our next speaker is Dr. Nur Azizan Zakaria. Is Professor Zakaria is already with us?
Yes, I'm with you, Cik Reni.
Yes, thank you, Professor. Maybe I would like to introduce a little bit Professor Dr. Azizan Zakaria. He is an esteemed practitioner in palliative medicine with a distinguished career spanning over 2 decades, if I'm not mistaken, from your CV. And he has been appointed as internal medicine clinical specialist in 2017 and has received a certificate from Malaysia National Specialist Registration in Internal Medicine in 2019. And today, Dr. Zakaria will present focus on the public health palliative care. Am I right, Dr. Zakaria?
Yes,
Thank
Cik
you
Reni.
so
Yeah,
much.
yeah. So,
Okay, please join me in welcoming Dr. Azizan Zakaria.
okay.
So, Dr. Zakaria, just reminder, the presentation will be 30 minutes.
Yes.
And then we will continue for the third presenter, third speaker, and then have a panel discussion. Okay, Dr. Zakaria.
Thank you.
Okay, Dr. Zakaria, now the time is yours for 30 minutes. Thank you.
Okay. Shall I share my screen or?
We will help you to share
Oh,
the
you
screen.
have seen. Okay.
Yes.
And I can control my own screen, right? Okay, so you will do it for me, or?
Yes, we will help you to control the screen, Professor.
Okay, the picture is on upside down. Can I start because I haven't seen my screen yet?
Okay.
Yeah, share
Anyone
screen.
can help me to share the screen?
Or do you want me to share my screen?
This is the screen, Professor.
Okay. And Cik Reni,
Yes.
I think my picture is upside down. Okay, can you see my face there? Or is that it's on your screen? Am I in the correct position or is it upside down?
I'm so sorry, Dr. Zakaria. The position
It's
is
okay.
not yet.
Is that my
David, can you help
camera?
me?
Oh.
Maybe Professor Camera can be turning.
The camera.
Yes, now is the correct position.
Yeah, but I don't know how to fix this into the. Let me see if I can.
Okay, great.
Okay. Anyway, it's
Great,
not
yes.
perfect, but it's okay. It's
Yes,
okay. Yeah, as long as
It's okay,
whatever
Professor.
whatever I'm gonna try to deliver, okay, hopefully that's, you guys will get something from it, okay. So again, Cik Reni, thank you for the introduction, okay. So my name is Dr. Azizan, Nur Azizan Zakaria. I'm an internal physician and palliative care physician here in Hospital Chancellor Tuanku Mukhris, okay. So yeah, I'll be talking about palliative care from the public health point of view. And then I will talk a little bit about the caregiver, the stress and the burden the caregiver. And then at the end of the day, at the last slide, I will try to give one example, one of the patient that I've been dealing with, okay, which is a true multidisciplinary team. And good thing is the patient still around, and patient doesn't really come to hospital anymore because they can get everything in the community setting by the public health system in our country. Okay, so before we start before we go into further details of what I'm going to talk about, I think it is very important to know the definition of palliative care. And I know everybody know the definition of palliative care, but I think I like to remind again. Okay, so the definition is very important because whatever we do, okay, especially when we explaining to the patient, the definition is very important because we want for them to know the objective of palliative care. Okay, as you're probably aware, there's lots of misconception nowadays because when you say palliative care, it's always associated with end-of-life care. This is not correct, okay? Because go back to the definition, okay? So the definition of palliative care by WHO is a care given to improve the quality of life of patient, okay? So not only patient, also the family member or the caregiver, the one who deal with the patient. Okay, so how do we improve the quality of life of the patient? So the way that we improve the quality of life is by reducing the symptoms. Okay, so any symptoms that the patient experience following the disease that they have. Okay, for example, patient who has cancer, who has spread to the bone, has metastatic disease to the bone, they tend to get loads of pain, severe pain. Like the previous lecture, you know, they talk about the opioid. So we use opioid for the pain in order to reduce the symptoms. Yes, sometimes we cannot make the pain completely zero. No, okay, because we're not God, okay, we're not perfect, okay, but at least we can bring down the pain to the level that the patient will be comfortable and at the same time give good quality of them as well as the carer. Okay, so, and then when we look at the patient, right, we look at the patient from 4 components. We look at from their physical component, we look at the psychological component, we look at the social component as well as spiritual component. So this is palliative care. We look at all these 4 components. That's the reason the delivery of service of palliative care best done by multidisciplinary team. Okay, so it involves so many teams. It involves the primary team, for example, the not chat. Yeah. Okay. They involve the primary team, the hematologist, the oncologist. They involve the palliative physician, involve the clinical nurse specialists. Okay. Involve the social workers, and in some places they have spiritual leaders as well. Okay. Especially when we talk about the spiritual issue. Okay. So how do we relieve the symptoms? We identify the symptoms when they are at early stage, because this is the stage that easy to deal with, okay? And then we do a thorough and detailed assessment, and then we know the symptoms, and then we treat the symptoms, okay? And then whatever we do, whatever service that we do, we will go by the patient values. Okay, what is patient values, okay? Patient values is like what we call goal of care. We sit down with the patient, we ask the patient, what do they really want? What can we do to help them according to their way? Okay, and this is what we call patient-centered care. All right. Okay, next slide. Okay, so as we know, okay, from the report by the WHO published in 2020, estimated 56.8 million people need palliative care services, okay? But unfortunately, only 14% received it, okay? Why so many? Okay, this is because, you know, we have growing aging population, we have loads of non-communicable diseases, and we have communicable diseases as well. And all those, okay, are increasing in numbers, okay? And at the same time, the medication, the technology of medicine is getting more and more advanced, okay? We can prolong people's survival, but again, you know, sometimes when you have a longer survival doesn't mean that you have good quality of life, okay? So that's what happened when we have so many chronic diseases, okay, because of the advancement of the technology, the medicine, okay, but they don't really have good quality of life, okay? So there's so many barriers that we need to overcome so that this, you know, small group of patients can get services in the community. Okay, so what do we need to do? This is when the public health, they call it public health palliative care. Okay, is very important. Okay, so that they can do something to reach the community and try to overcome some of the barrier. Okay, so next slide. Okay, so what is public health? Okay, you know, when you look up, okay, the definition of public health is the science of protecting and improving the health of the people and their communities. Okay, so this work is achieved by promoting healthy lifestyle. They do research of the disease. Okay, they prevent injury. They detect and prevent and respond to infectious disease. Okay, so they emphasize on community development, health policy, public education, and health promotion. Okay, one thing about public health, right? They use community as an integral part of the care delivery. Okay, so because they are already in the community, so they take community as the main delivery services to reach the public. Okay, next slide. Okay, so like I said, palliative care, we care for patients' symptoms from physical, psychological, social, and spiritual component. Okay, but the public health care, okay, they emphasize the positive aspect as a result of terminal illness. Okay, so what do they mean by positive aspect? Okay, for example, you have somebody who sick, terminally sick at home, right? Okay, and when somebody is sick at home, all the family members tend to visit this patient. So they kind of like have a family reunion. So this is the positive aspect, okay? So maybe they haven't seen each other for a long time, but when they visit somebody really sick in the family, they tend to meet together, okay? And then they tend to have a conversation and those kind of things, okay? And another thing is that if the terminal patient tend to have like a cancer, like for example, colon cancer. So the positive aspect is they remind the whole family member to go for screening. Okay, so like, you know, colon cancer, breast cancer, there is a screening available. Okay, so when somebody is sick because of this cancer, okay, they remind the rest of the family member to go for screening. So this is the positive aspect. Okay, this is part of the public health. They emphasize the positive aspect. Now, and then both palliative care as well as public health, right? They extend the care for the caring network. Okay, so that means that when they extend the care to the caring network, the one who look after the patient, okay, so automatically it will involve the community, and then as a result, it goes into the society. Okay, so as like I said, you know, the carer or the sick patient, right? They maybe they maybe have a job before, they may be working before. Okay, so when they extend into the community, they automatically they goes into the workplace. Okay, and then, you know, if this patient has a religion, they go into the worship area, the worship in the mosque, okay, where people talk about this patient. Okay, and then sometimes they go into the education institution as well. Okay. Next slide. Okay, so what happened is public health care, palliative care, they care for the family who care for the patient. Okay, they look at the impact of the effect of this carer living and looking after who somebody really sick. As you know, looking after sick patient is not easy. It's a very demanding job. Okay, it's 24/7. Okay, that's why my patient, if he or she want to go home, I always remind the family member, you have to have at least 2 people to look after you. okay, you have to take turn. Otherwise, it's going to be very stressful if one person looking after the patient, okay? So, and talk about the social mobilities. For example, this carer, they have job, but because they have to look after somebody really sick, they have to resign from their job, okay, to look after this sick patient, okay? And then, they tend to be together, the carer and the sick patient, okay? So they don't really mix with the society. They tend to be very lonely, okay? So this is what we call social morbidities. And then what about people who has communicable diseases such as HIV, AIDS, they tend to have stigma as well as social rejection, okay? So the public health palliative care, the role is to do harm reduction, to do early intervention so that the harm can be reduced, okay, and to prevent the social stigma or rejection from getting worse, okay? So, and at the same time, they promote of healthy well-being in the context of dying, loss, and caregiving. This is what I said before, the positive aspect of the of the terminal illness, okay? So when somebody is dying because of the cancer, okay? So for example, like a cancer which is screening tools, screenings is available, for example, colon cancer, breast cancer. So it reminds the whole family member, okay, to go and get screening. So this is a promotion of health and well-being for the for a family member. Okay, next. Okay, so communities is very important, okay, because it is part of the network, okay. So like when somebody really sick in the family and these patients are dying, okay, it's not individual issue. It's not professional issue. It's not only doctor and nurses, okay? It's everybody issue. It's a social issue because it can affect the caregiver, it affect the family, it affect the society as a whole, okay? So I give you one example when I said this is a social issue. If some patient, okay, who choose to die at home, because we do have what so-called terminal discharge here in Malaysia, and I believe there is such a thing as well in Indonesia. And this patient have a terminal disease and they want to die at home, okay? So we need to move this patient from the center, from the hospital to home. Okay, and it's not easy. It's very challenging, okay? It's very challenging to the carer, to the family, especially if they do not have experience looking after the patient, okay? And it can be very challenging as well to the neighbors because they know that they have somebody really sick next to their house, okay? So that's why, okay, we public healthcare, we together with the public healthcare here, okay, we try to provide support. Okay, so we try to support to this patient. For example, what we do have a hospice care here, which is in the community, which can reach public and sick patient at home. Okay, and then we educate the family, the carer, how to look after the patient. Okay, how to deal with the symptoms. When we also provide sometimes 24/7 tele helpline so that this family, if they have any issue, they can call the helpline and they can get a direct information or advice or suggestion how to deal with the issue. Okay, so next slide. Okay, this is another issue by the public health care. Okay, so access to the palliative care is very limited. Okay, like I said, WHO 2020 report say, there's like 56 million people requiring palliative care services, but only 14% received it. Okay, so this is because some of these people, they are in the low and middle income countries, And some of the patients, okay, individual, they are in the rural communities, and some have disabilities, okay, and then some have a transportation limitation. So these people not able to go to the big city to get palliative care services. Okay, so that's the reason why public health is very important. When they integrate with the palliative care, they will try to educate the public, the communities, and then from there, whatever they educate can reach these people in the rural area. Okay, okay. So how do they do this? They have like, everybody probably know the Ottawa Charter. They have 5 pillars. Okay, public health care, palliative. They have 5 pillars. Okay, next slide. Okay, so what are those pillars? Okay, they have health-centric public policy. They have supportive environment. They have community action. They have a personal skill development, and then they have health and social care services toward health promotion. Okay, so take all these 5 pillars, okay, put them all together. Okay, so for example, we take people who are in the community, GP, we take people in the community, public health nurse, we train them. Okay, we train them, we educate them about public health. Okay, so we make them as a intermediate level palliative care services. They're not specialists. Specialists who are people who are very trained. For example, like here, I'm trained to be a palliative care specialist. Okay, but these people, I train them, we train them, okay, in the community, they become intermediate level, okay, so that they can address all the services to people who are not able to come to the center, to the hospital, okay? So they reach the people in the community, okay, in the rural services, okay? So they provide the palliative care services, okay? So, and this group of healthcare workers, we provide them with all the information, the services, the training and everything. So they will bring whatever they learn to the community, to the public, and they make the patient feel empowered and supported. Not only the patient and the carer, okay? So everybody will feel supported because there is somebody that they can rely on if they have any issue, okay? Next slide. Okay, so what can they do to improve access? Okay, so number one, they can integrate palliative care into a national healthcare system. Okay, so every country, they have a national health system policy. So what they can do, they can integrate the palliative care into their policy, and then they don't forget, when they're discussing about budget in the meeting, include palliative care as well, okay, where they need a standalone budget in order to, to provide all the services in the community, okay. And then number two, they educate the community, okay, and the public about palliative care. How do you educate, how you let the public know? There's so many things that you can use, right? You can use a social media, you can use the influencer, okay, you can use the middle person, like example, the general practitioner, the community nurse, okay, so that they can disseminate all the information about palliative care. And then not to forget these healthcare professional who are near to the community, such as the general practitioner, the nurse, okay, the public health nurse, the community nurse. We need to educate them so that they can deliver a very good service to the community. Okay, next. Okay, so now we go to the caregiver. Okay, I know everyone want me to talk about the family perception, but I think this is the most important topic to talk about because we tend to forget caregiver, the person who look after the patient. Okay, so I think it's very important. I feel so I feel I have the responsibility to let people know, okay, being a caregiver is not an easy job, okay? And this is the person who responsible for the patient, general and medical care. And this is the person that, you know, they get all the information from the doctor, how to deliver care to the patient, to the sick patient, okay? They're not being paid, okay? They're not being paid, okay? So this is what we call informal caregiver, okay? They sometimes they resign, okay, because they want to be a full-time carer, okay, and sometimes they just have to forget whatever their social life in order to care for somebody who really need a care at home. And they are human beings, okay? They can face stress, okay? And when they're very stressful, it will affect their well-being and health status. So when they're very stressful and the health status has been affected, they will not be able to deliver a very effective care to the patient. So that's why we need to care for the caregiver, okay? And it's very important because, like, you know, doctors in the center, like in the hospital, we cannot reach to this caregiver. We need a public health, okay, public health doctors, public health nurse, okay, or officer in the public health to go and screen for the caregiver, okay. So they need to provide psychosocial support, and then they need to provide this caregiver to promote self-care. Okay, next slide. So look at the data, okay? Like when I was in New Zealand before, you know, when somebody, for example, a patient, elderly patient, when they sick and then they cannot go home, instead of going, telling the doctor that I want to go home and my family will look after me, they will tell the doctor, get me a nursing home. Okay, so look at the prevalence. It's small in New Zealand. Okay, but we go to Finland. Okay, 44% tend to be at home to be looked after by the caregiver. Okay, now we talk about Asian country. Okay, I'm not sure whether this same thing is happening in Indonesia or not, but in Malaysia, when somebody really sick in the family, for example, the wife is sick, okay, the husband will feel responsible to care for the wife, okay, and then when somebody has mother is or father very sick, okay, the son or daughter will feel responsible to be the carer, okay. So we don't really send, you know, our family member to nursing home, okay? So we bring them home, we look after them, and we become an informal caregiver. Yeah. So in Malaysia, when we did a national survey, it shows that 5.1% of Malaysian adults provide informal caregiving. Now, what about the problem about informal caregiving is, you know, sometimes they can be very stressful. The more the burden, okay, the stress the situation will be, the more stress that the caregiver will experience. Okay, so when we look at the local cross-sectional study, okay, we use the Zarif Burden Index, okay, the caregiver's burden is approximately 47.4 to 92.8%, okay, in Malaysia. I'm not sure the data in Indonesia, or whether you know, it probably there as well. Probably the public health you know, sector services have done a study about the caregiver stress in Indonesia. I'm not sure whether it's more or less the same, okay, but this is the data that we have in Malaysia. Okay, next. So the risk factor, right? So the risk factor, so it's divided into three, okay? Number one is the carer characteristic. Number two is the patient characteristic, okay? And number four is the environment, okay? Now, the older the carer is, the more risk factor for the adverse outcome, okay? And then the lower the education level or the more health condition that they have, they have more adverse outcome. And then another thing is that lack of knowledge in caregiving. They don't know what to do. They don't know what medication to give. They don't know how to do the dressing. Okay, they don't know how to do the turning. They don't know how to look after the patient. So they become more stressful. When they become more stressful, there will be more adverse outcomes. Okay, and then some people who tend to be alone by themselves, they don't really mix. They don't really talk to anybody. Okay, so they have very limited social network. This is another big factor that can cause adverse outcome. And then if you look into the patient characteristic, patient who has dementia, okay, very demanding, high level dependency, okay, they need to be fed, they need to be showered, they need to be cleaned, they need to be changed, okay, using diapers and everything. Okay, this is the characteristic patient that make the outcome even worse for the carer. Okay, and then what about people who have distressing physical symptoms? People who has cancer, like very big wounds, smelly, okay, very painful, and the patient keep shouting and shouting. They can make the carer become stressful as well. Okay, and then when you look about the environment factor, okay, if the care is long, like months and months and months, and then it goes to year, okay, it makes the carer become easily burnt out. Okay, and then people who has financial issue, okay, and then they live together in a small place, okay, this is the one that can cause more stressful environment. Okay, next. So how do you overcome this? What strategy do we have? Okay, so again, the public health services, okay, they need to reach these people in the community. Okay, they need to educate the carer. If they need support, please ask for it. Okay, and then they help this carer if they can adjust the time to work, okay, adjusting paid work so that they can fit with the caregiving activities, and at the same time they can get financial support from the work that they do. Okay, and then for spiritual leaders, okay, in the community, okay, so they maybe can channel this patient towards more religious or spiritual belief, okay, in order to cope with the stress that they have. Okay, and then again, in the community, the healthcare professional, okay, they can try to enroll the caregiver to a support group so that they can discuss, okay, the experience, the stress of level that they have, okay, and then what ways, do they try to overcome the stress, okay, and then a certain country, right? For example, when I was in Ireland, when I was in New Zealand, okay, when the public health officer, okay, the social worker detect there's a high level of stress in the carer, okay, so what we do, okay, we take the patient to provide respite care, maybe 7 days, okay, maybe 14 days, okay, so, and then we provide them 3 to 4 times a year in order to give the carer a rest, in order for them to recuperate, okay, and try to bring down the level of stress, okay. And another thing is what we do, we sometimes take this patient for respite, okay, and then we call the carer to come over, and we provide training and education to make things easy for them, okay. And then from the community, okay, we try to negotiate with the employer, okay, so that maybe the carer can continue working at a very flexible time. And then we try to provide a financial, we try to get the government to provide a financial relief or assistance to the carer, okay, and then sometimes we can provide a support. For example, we get like somebody to come over to visit the carer, maybe like once a week or maybe twice a week or something like that, in order to help them, to give them support. Okay, next slide. So, okay, so what can we do? So if you do go and if you do meet with the carer, okay, ask them, okay, always ask them, how are you? Okay, because sometimes if you don't ask them, they they may be afraid to tell you. Okay, some people, especially we are Asian, we try not to talk about this kind of thing because we feel so not appropriate talking about this thing, okay? Because we always feel responsible looking after our family member who are sick, right? So we try not to talk, okay? So ask them, how are you? Okay, and ask them, how are you coping so far? Okay, and explore more. Okay, what about yourself? Do you look after yourself? Okay, did you get enough sleep? Did you get time to have your meals? Okay, and what do you do to take a rest? Okay, do you get somebody to help to look after your father or your mother so that you can have a rest, you can have a time off? Okay, so we ask this kind of thing, okay, and I suggest them, what about like getting help from the rest of the siblings, okay, the family member, okay, and then can you like get somebody to help you at home, like a hired caregiver or a maid, so that will help the caregiver as well. And then lastly, don't forget, okay, if you can ask the caregiver, is there anything that you can offer to help? Okay, so I know if anything that you can help, you can do, okay, do help them because they definitely need some help. Okay, next. Okay, like I said, in palliative care, the symptoms is easy to deal with when it is early. So that's why we encourage, okay? So if, you one of the public health officer, okay, you encounter cases in the community with need palliative care referral, so do refer early in the course of the disease, okay? Because the earlier you refer, it's easy for us to deal with the issue, okay? So, and then the early you refer, the more the quality of life of the patient will be improved, okay? So, and then it can reduce unnecessary hospitalization, and it can reduce the use of healthcare services, okay? So the reason why it's good to refer early, besides helping the symptoms, we can develop rapport with the patient, with the family, we can develop trust, okay? And then we can get patient values. What do they really want in order how to deal with the management of their disease, okay? So this is what we call goal of care. We sit down with the patient, okay? We talk to the patient, okay? We ask them, how do you want to manage your case? Okay, so and then we go from there. We will be with the patient until the end of the journey. Bear in mind, especially when somebody has a cancer, when somebody has like a heart disease, okay, as the disease get progress, the journey is going to be very, very difficult, okay? It's going to be a winding road, okay? So you just have to be there, okay, to provide your support to the patient and the family until the end. So they will feel supported, okay?
Dr.
Next.
Zakaria, sorry,
Yes, sir.
we only have 5 minutes left.
Okay.
Okay, thank you.
Yeah, I think it's only like 1 or 2 slides to go, right? Okay. So this is another thing, okay? You guys, if you're a public health officer, if you are a pharmacist in the community, okay, this is all the misconception about palliative care, okay? So you need to correct this conception, okay? So one of the misconception, right? They said palliative care is only for people who are approaching end of life. No, okay? Like I said, the earlier the referral, the better. The earlier the referral, it's easy for us to deal with the symptoms, okay? And then even if the patient still on ongoing treatment, you can still refer them, okay? So because why? Because the definition of palliative care, improve quality of life, okay? If they have a symptoms, we want to improve quality of life, refer to palliative care, so we will deal with the symptoms, okay? And again, when we deal with the symptoms, we look at 4 angles: the physical, the social, the psychological, and the spiritual, okay? So do refer early, doesn't matter, okay? And then next, they said it's only for people who have cancer. No, okay? So you can refer people who has a chronic disease like a chronic heart failure, people who has like an end-stage renal disease, okay? And they do not opt for hemodialysis. They just want to be conservative conservative. We do have people with the HIV, AIDS, okay, with all the symptoms, okay. We support them psychologically, we support them physically, and we support them spiritually, okay. So we support everybody. It doesn't have to be cancer, okay. And then again, it's only people who have physical symptoms. That's not correct, because we look at patients from 4 different component angles, okay. And then the priority is to have best quality of life. We also helping family member. It's not the patient only, okay. We help the family and the friends who are affected, okay. Maybe not directly, but indirectly by referring them to somebody who really can help them in the community. Okay, next slide. Okay, so you guys, the public health, okay, personnel, okay, officer, play an important role to correct this misconception. Okay, so again, how do you do that? Definitely educating the public. Okay, we target the GP, the general practitioner. We target the community nurse. Okay, because these are the healthcare professional in the communities. Okay, we educate them so that they can bring all the information, all the education, all the training to the public, so that public know what is palliative care, palliative care services. Okay, and then public health, public health, public health services as well. If you can develop guidelines and tool in palliative care that can be used across the disease. Okay, so not only one disease, cancer, it can be used in all the disease, especially chronic kidney disease, heart disease, and communicable disease. Okay, next slide. Okay, so palliative care is about improving quality of life of those patients and their carer. Okay, so the cohort of patients, from life-limiting illness up to those with a chronic disease. Okay, so this is the patient: cancer, cardiovascular disease, respiratory disease, all the breathlessness. Okay, respiratory disease, diabetes, aka AIDS. So this is the one with high needs of palliative care because of the symptoms. Okay, and then liver disease, kidney disease, rheumatological disease, neurological disease, and and all those things can be referred. So bear in mind, the main symptom that we see in this kind of patient is breathlessness and pain. Okay, and then as per previous lecture, we use opioid for breathlessness as well as pain. Next slide. Okay, so this is like one of the example. Okay, a case that I just want to let the audience know. I have a 74-year-old gentleman who had 2 admissions previously in the hospital, one in 2019, one in 2020. So he had stroke, okay, CVA in 2019, and then another admission in 2020 because of stroke. Okay, after the second stroke, his MRS score is 5. So MRS score stands for Modified Ranking Scale score. That means that patient is 5 is bedbound, fully dependent, full nursing care, okay, pack tube feeding, and he's unable to communicate. Okay, and then because of the stroke, he had seizure. Okay, and because of the stroke, he cannot even swallow his own saliva. Okay, and because of the stroke, he tend to get loads of expression pneumonia. Because of the stroke, he won't be able to swallow properly. Okay, so he has full-time caregiver. Even though he has full-time caregiver, he lives with his daughter and his frail wife. His daughter was so stressed and burnt out that she had to be absent from work multiple times to bring his dad to hospital. On top of that, for him to come to hospital, they have to get ambulance to bring him to hospital. Okay, so patient was referred to us for introduction to palliative care. Next slide. Okay, so this is what we do. Okay, we reviewed the patient to know his main issue and his comorbidities. We arrange a family conference to get collateral history from his to get his collateral history, the main problems, and then what is the main concern from the family. Okay, and then from there we can we got the impression that his daughter was very stressed and burnt out. Okay, so through the family conference, we managed to get patient values and goal of care. So for the symptoms of seizure, we control with Keppra, we call it Keppra, levetiracetam, and clonazepam. And then for the stiffness, we use a baclofen. The stiffness is following the stroke, okay? And then because of the episode of shouting and severe cough, so we use low dose morphine for these symptoms. We believe the shouting is because of pain following the stiffness. So we use morphine, and then for the cough as well, because he had like a bout of cough, multiple cough, non-stop. So we use morphine to depress the cough. So next slide. Okay, and then for the saliva, we use glycopyrrolate. We give it through the PEG tube, and then we educated the family. If mouth is too dry, the glycopyrrolate can be reduced or stopped for a short period of time. And then we suggested for him to have oxygen concentrator just in case at home he needs the oxygen to relieve for the occasional dyspnea. And then from the family conference, the goal of care is very clear. The main priority is to keep father comfortable. If any more chest infection, especially pneumonia, they will keep him at home for oral antibiotics, okay? And we finally transfer his case to domiciliary palliative care services for home visit. And so far, he never been admitted to hospital for nearly a year now. Thank you very much.
Thank you very much for Dr. Zakaria for that insightful presentation. Your insight into like a multidisciplinary team for palliative care, also about the not only the patient, but also the families and also caregiver is important about the palliative care, and also the insufficient access for the palliative care is have certainly give us a lot to think about. Thank you, Dr. Zakaria. And I hope Dr. Zakaria and also Professor Manit will still stay with us in this plenary session and also in the discussion. And I would like to remind to the participant, you can write down your question into the chat box, and also you can also raise your hand in the plenary in the discussion section. And our final speaker is Dr. Caroline Pillen. Dr. Pillen, are you with us now?
Yes, I'm here.
Okay. Thank you so much.
Start my video.
Okay, let me a little bit introduce Dr. Caroline Pillen. Dr. Pillen is an expert in the field of palliative and end-of-life care with over 28 years experiences in nursing career. And also, she held an PhD from the University of Newcastle, and she's published extensively in leading journals. So many journals, so many research in the leading journal that published for the Dr. Pillen. And today, Dr. Pillen will share her insight on the how to manage pain through multimodal approach. And please join me in welcoming Dr. Pillen.
Hi,
Thank
everyone.
you, Dr. Pillen. Yes.
Uh,
I just
sorry.
remind that the presentation will be 30 minutes, Dr. Pillen. So now the time is yours. You
Are
can
you
start
happy
from now.
for me to
Yes.
run my presentation? Yeah.
Yes, Professor. We can share for you the slide.
Yep. Okay. That's it.
Okay. This one, the slide. Okay.
Yep. Yeah.
Thank you.
Thanks. So I'll get you to go to the next slide. That's it. Hello. Hi, everybody. My name's Caroline Phelan. Thank you so much for inviting me to speak today. I'm going to be talking about pain management approaches in palliative care, and specifically those approaches which might be considered non-pharmacological. I'll go to the next slide, please. So I think today our focus is really about how pain can be managed in many different ways. When we come to our patient care, we consider a multimodal approach. And that is true of many things that we do, including pain management. You've heard others discussing medication, so I'm not going to speak about medication today, but I want to acknowledge its important role in our pain management approach. Next slide. So I think it's important to anchor in how we consider pain, and certainly from our previous speakers, this concept of pain as a personal experience is really important to reinforce. Pain is whatever the person says it is, but it always occurs in a context, and that context is biological, social, psychological, and environmental. And I just want to quickly note that all the references that I'm referring to today are at the end of my presentation, and I'll hopefully make available to you if you need them later. Next slide, please. So when we consider pain in the context of a person's life, we look at the biological, the psychological, and the social aspects. And that means we need to consider many, many different things. Pain occurs because of biology often, which can be associated with tissue damage, and other factors such as treatment for cancer or the cancer itself. Our psychology, which is our memory, our coping mechanisms, our mental health, our stressors will impact, and our social circumstances, what sort of support networks do we have, and what is our societal beliefs. There is another factor, and I'll go to the next slide, please, that we want to add in that is another component, which is the spiritual. And particularly when we talk about palliative and end-of-life pain management, we need to consider the spiritual aspect, which is someone's faith, the meaning they attribute to their life, the purpose they might have, and their personal identity as well. Next slide, please. So pain perception is something we need to consider always. And this is a really important process where we consider the environmental and personal impact of pain. So the way we see the world impacts on the way we perceive it. And patients are influenced by who they are and what they believe and how they have previously experienced their world and how they have experienced pain as well. Next slide, please. So here you can see a pain event. You have the brain experiencing pain, and it's putting in the historical, biological, and social determinants around that experience, the current social determinants that the person might be experiencing, plus their biological situation, and that turns into how they express their pain. Next slide, please. So, as important as how somebody perceives pain is how we as healthcare professionals, what our attitudes and beliefs are towards pain and towards particular patients. The way we think about something influences how we perceive pain, but it also how we perceive our own pain, but also how we may perceive pain in others. And that's a very important thing that we need to remember, is that we as healthcare professionals are also working in a context. We're tired, we're busy, we're stressed, and that can also influence how we perceive someone's expression of pain. Next slide, please. Here we have what we call the social communication model of pain. And this is an important thing that I think we all need to remember as clinicians and healthcare professionals. When a person is in pain, they will have a personal experience, their memories and their history with the pain or the disease process, which, as I mentioned before, gets wrapped up in the biology and then turns into their pain expression. They then express that in a non-verbal way, or perhaps with self-report, to a caregiver, and that could be you as a healthcare professional. You then make a pain assessment, which is a form of decoding that expression, and then you create a pain management plan. And it's really important that we remember that our own perceptions are influencing the way we assess pain. Next slide, please. So I'm going to talk now about some practical approaches using the biopsychosocial model and including some spiritual aspects as well. And to provide you with some useful tools to carry forward in your clinical practice. Next slide. It's always important to remember biology, and it's certainly really important to identify the physical cause or the biological cause of pain. Now, it could be a disease process. It could be pain associated with the treatment that somebody has received. But other aspects that are often not as highlighted, particularly in a palliative and end-of-life care setting, are the other aspects of our biological approach to pain management, which is movement. So inactivity actually can lead to increased pain. And a great saying that we often say is movement is medicine, so keeping our movement going. And nutrition, how we optimize our nervous system functioning through aspects like nutrition is really important. Next slide, please. Moving without fear is really important, and it's something that is a real struggle when somebody has experienced pain. It's often around setting pacing goals, but also helping people move with purpose. So ensuring that people have a goal of care, and that goal of care might be that they, want to spend more time with their family. So how do we help that person sit up in a chair? How do we help them, be able to get in and out of a vehicle so they can travel to visit their family, those sorts of things. So we can construct our pain management plan with movement by including that purpose. Another aspect is palliative rehabilitation. So next slide. This is a newer approach around how we keep people active. It aims to enable people to live fully until they die. And this is about embracing the fact that people still have goals, they still want to have purpose, and they still want to be part of living, even though they have a terminal illness and they are reaching the end of their life. Palliative rehabilitation integrates rehabilitation, self-management, and self-care as much as the person can do themselves. It focuses on optimizing function in spite of disease and progression. And I recommend everybody, the Hospice UK website has a great understanding of palliative rehabilitation or rehabilitative palliative care, and it has quite a lot of really useful resources. Next slide, please. The way we feed our bodies is also the way we nourish our central and peripheral nervous system, and it's important to remember optimizing our nervous system health. Movement is one way to do that. Another way is with foods and nutritious foods. So we know, for example, whole foods are much better than supplements, but we also know that optimizing minerals like magnesium, for example, can be very helpful in pain management, as can optimizing omega-3 to omega-6 nutritional ratios. Obviously, as people enter a palliative care and as they come towards the end of their life, eating may not be a primary focus and might be something that they have difficulty with. But if we can optimize that nutrition as best we can, we are giving them every opportunity to at least manage their pain as best they can. And of course, the joy of eating might actually be a major goal, particularly somebody who's had family connections or major connections in their life around eating. Next slide, please. One of the aspects that we often talk about in this area is the psychological approach to pain management. And we can generally divide these up into some major areas. Cognitive behavioral therapy is a very commonly used practice across many healthcare settings. But I think one of the things that we can do is use patient education, managing our anxiety and fear, and distraction as well. Next slide, please. Oh, by the way, that's it. So patient education is a really useful tool. when a person understands what is happening to their body and what is happening with their disease process and what they can expect, it does reduce fear. We know biologically and in an evolutionary sense that pain is an alarm signal to our body. So we want to be talking to our patients about whether or not they should expect pain and how much pain they should expect. This can really help reduce somebody's fear around pain and fear around movement as well, which is really important. We know that empowered patients, so patients who have control over their pain management, so they choose when they take their medication, use significantly less opioid. And for us to fully empower our patients and provide them with optimal control over their pain management, we need to make sure they're well educated and well supported. Next slide. One of the things that I just want to say is skills in communication are incredibly important, and there are free online education modules available. End of Life Essentials is one of the projects that we run here out of Flinders, which help train healthcare professionals on how to empower your patient, how to help them understand what is going on with them, and setting clear communication goals as well. Next slide. So managing anxiety can be a really difficult thing for everyone. Not all pain is biological in its origins, and we need to make sure that we're setting functional goals for movement so that people are able to move and keep moving, but we're also wanting to make sure that we're addressing people's fears. So we're asking them about, what are they worried about? What are their concerns? What are the issues that they have? People may not recognize that their anxiety is stemming or is influencing their pain management. And certainly when we come to issues like procedural pain management, it's really important to recognize how we manage anxiety before we start a procedure. There are medications, obviously, that we can use, some anxiolytic medications, and there are newer medications which we're using all the time, clonidine, the alpha-2 agonists, for example, dexmedetomidine and clonidines, to help reduce anxiety for procedural pain management. But sometimes talking can be the best thing to reduce someone's anxiety and reassurance as well. Next slide. Distraction is an incredibly powerful tool in our psychologically based arsenal to help manage pain. Distraction, and it's really important that we recognise that there is a difference between passive participation, and active participation. Somebody sitting in front of a television is passively distracted, and that is okay, but it's not great. What you want to do is anchor the person's distraction in an activity. One of the best things we use in pediatric pain management are these small flip cards which have very tiny images on them, and then we ask, and there are various different objects, and we'll say to the child, can you find the blue umbrella? And they have to search the card and the image to find the blue umbrella. That's an incredibly effective way to create simple distraction. Obviously, there is new techniques now with virtual reality. Computer games are fabulous at being able to take somebody out of their context and place them into an exciting world. It's useful to anchor an activity or an active participation activity in somebody's personal interests and their goals. It helps reduce pain. It helps them manage their pain. Next slide, please. Obviously, the social context of pain is incredibly important. People in pain feel isolated, and it's interesting how we go to engage family and community as well. And that can mean having to get help from outside of the immediate family to help engage people and bring them out. Next slide, please. It's common, any sort of pain, and any prolonged pain can make you depressed, anxious, and angry. And knowing you're going to die can also make you depressed, anxious, and angry. But humans fundamentally seek connection with one another. Now, not everybody, obviously, and there will be always some patient who prefers to be on their own and manage their pain in isolation. But generally speaking, we know that when a patient reduces their isolation and they make that human connection, their pain is better managed overall. Next slide. I think an important aspect, particularly around palliative and end-of-life care, is the concept of the spiritual aspect of our biopsychosocial model of pain and health. We know that when somebody has a very strong spiritual background, maintaining that through their illness and maintaining it through their treatment process is really important to them. But it's important you invite your patient to engage in what they feel comfortable with. And it's important that they're able to express their hope or their personal spirituality as an individual. I just want to talk quickly about severity and tolerance. Next slide. We know that, for example, spirituality does not remove the experience of physical pain, but there is some solid research that suggests that patients report the same levels of pain, but are able to engage in more activities. So whilst their pain is as severe as it would be, they're able to tolerate the pain much better. And there's some really good research around, particularly with older people particularly older people and their ability to tolerate severe pain with distraction and engaging in spiritual activities. So it's quite a useful technique to try and engage with. Next slide. I think one of the really important things we want to do is make sure that you're preparing yourself and your team for what you need to do to be able to engage your patients in these different aspects of pain management. And it's not just about pain as well. I think it's really important to note that the biopsychosocial model that we use is something we use across all aspects of healthcare and is incredibly effective in other symptoms associated with end-of-life care, like breathlessness, for example. When you manage someone's anxiety and fear, you can help them manage their breathlessness better than just with medication alone. So a well-trained workforce supports all aspects of pain management. Understanding your role within the multidisciplinary team and engaging within the multidisciplinary team is really important to help build a total person's pain management plan. Caring for yourself as well can be something that is incredibly important. I know our last speaker spoke about that. It is a crucial point. Commonly, when you witness suffer, you suffer yourself. And managing somebody's pain at the end of life can be stressful, and it can lead to stress within your team as well. So being able to fully debrief is really important, and discuss pain management plans in an open and honest environment is incredibly useful as well. Next slide. So I've just got a bit of a plug for Flinders University there, which is where I'm currently employed. And it is just around some of the short courses that we run, plus our postgraduate program. Again, engaging in your team development is really important as you deliver palliative pain management. Next slide. So I've just got a list of references in the next two slides. I hope I've come okay for time. I tried not to be too long. And just next slide, please, for the next list of references. There's some significant research for you all to have a look at. So I'm not sure if you're going to receive this presentation, but I'd be happy to email those to anybody at all.
Thank you so much. Thank you so much for Dr. Pilan for the wonderful presentation and so interesting. And about the managing pain in the palliative care is how to manage the pain. So we already have with us 3 of the speakers, and now we open for the question. Maybe anyone will raise the hand and then directly give the comment or question, please. Okay, actually, we already have several questions, Professor. Maybe for the first question that already in the chat box is for Professor Manit. The first question, Professor Manit, is from our students. She asking, may I ask about how do we balance the need for effective pain relief with the risk of addiction or dependent on pain medication in cancer patient?
Okay. According to the question, I already mentioned about the hello. Can you hear me?
Yes.
Okay. I already mentioned during my talk that is for the pain control. If the patient have the real pain, the dependent is very low incidence. But if you see the patient who are at risk of the drug abuse or drug addiction, most of the time for us, we already check through the opioid risk to check that the risk of the addiction of the patient. But you need to balance for the pain control and the drug addiction, because that if you're concerned more about the addiction and you not give the patient a good enough for the pain control, it really affect for the patient quality of life. So my conclusion is okay, if you're concerned about the addiction, you can do the scoring system to see the risk of addiction. By the way, you need to give the patient with the appropriate pain control. After the patient get that, you need to make sure that the morphine is not much more than the patient requirements. And you need to check for the patient drug supply. If the patient have enough morphine or the opioid, you do not need to fill up the patient medication more than the patient need.
Okay, thank you, Doctor. And I think we also have the second question for Professor Manit, also from our students. I want to ask if the patient feels severe pain, is it allowed to give double analgesic such as tramadol with codeine, or maybe another combination of the analgesic, Professor?
Okay, so for according to the pain severity score, so if the severe pain, most of the time we provide the patient with the strong opioid much more than to use the codeine or morphine, which is the big opioid. And combination codeine and tramadol together, because these both are the big opioids, cannot increase the effect for the pain control anymore. I suggest you, if you want to use the combination, I suggest you change to the strong opioid should be better. And in combination with the drugs, between the drug for the pain control, there are some data. For example, for the patient who have the bone pain from the cancer, you can provide the opioid combination with the NSAID or the some COX inhibitors. It has the data to show that it can better pain control compared with the single opioid management. And in addition, for the patient who have the combination pain of the nociceptive and the neuropathic pain, you can combination drugs of such as the opioid and the medication for neuropathic pain such as the gabapentin or the pregabalin to make sure that the patient can control both of the nociceptive and the neuropathic pain because some patients we have the mixed pain.
Thank you so much. The answer from the Professor Manit. So to check
Sorry, Reni,
yes, Professor.
can I ask Professor? Is it okay? Sorry, Prof. I just wonder if I can ask you one question. Like,
Okay.
like you said, in somebody who has really severe pain, right? We
Yes.
can use opioid and we can titrate the opioid and those kind of things. And then you said there's a certain study says adding the what do you call it, the NSAIDs, the celecoxib, it may reduce the pain severity. But what about in cases who patient with cancer patient, terminal, I mean, like they're not really terminal within 1 or 2 weeks. They may have like months to go, and they come with severe pain, and they come with like deranged LFTs, CKD stage 4, which limit the usage of the NSAIDs and the celecoxib. So what approach will you do?
Okay, you mean the patient have the severe pain and also have the renal dysfunctions.
Yeah, renal dysfunction, liver dysfunction, So like we like in Malaysia we have loads of people who has hepatocellular carcinoma, and then they tend to go into hepatorenal syndrome. So they kind of like limit our usage of morphine, the oxycodone, So we end up giving them alfentanil or fentanyl. So, and then I can't really give them NSAIDs, cannot really give them celecoxib because it's going to make the kidney worse. So other option that, what's approach do you do in your center?
Yeah. Because that if the patient have both renal and hepatic dysfunction, it's really hard to adjust the dose of the drugs. So by the way, for the patient who have the severe pain, I also suggest to use the strong opioid should be better of a drug of choice to control the pain for these patients. And we can use, I have experience to use the morphine is that kind of try group of the patient, but you need to be carefully increase the dose of the morphine according to the pain symptom of the patients. Most of the time, we start with the short acting first and see how the patient responds for the pain control. If the patient can tolerate with that symptoms, the pain symptom with the appropriate dose of the morphine or the strong opioid, we can stay with that dose. But sometimes the patient who have the progressive pain because the disease is more progression and we cannot control the pain at the same dose that we already used for that patient, we still back again and just slow titrate the dose of the morphine by using of the short acting or the immediate release morphine better than you provide the big dose of the long acting or the extended release. Because if you use the high dose or the extended release, if the patient have the toxicity of the drugs, it's very hard to reverse because there's the long acting will cover the duration action is very long for 8 to 12 hours. We don't want to face the patient to have the respiratory depletion more than long for the long time than that because it's not good for us to provide the naloxone repeated dose more and more.
Thank you, Prof.
Thank you. So interesting discussion. We have my colleagues. You have some question, please?
Thank you, Bu Reni. My question is my first question is actually for Professor Manit, but already answered just before. So I have question for Dr. Nur Azizan.
I
Okay, doctor, you already explained to us that career or family with patient palliative have suffering also, not only patient but also the family has another problem like that. My question is in Malaysia, is there any role or any special treatment for family to deal with family with palliative care? Or how to prepare the family caring with patient with palliative care? Thank you.
Okay, thank you, Juan Yayu, for the questions. Very good questions, very good question. I think because we are like, you know, Malaysia, Indonesia, we are more or less the same. Okay, so unfortunately, we're not like Australia, we're not like New Zealand. They have a very good support for the carer. We still kind of, I would say, behind. You know, we still, palliative care is very small here in Malaysia, and I would say it's very small as well in Indonesia, right? Okay, so what I will do, okay, if I detect a family member who are very stressed, they kind of like burn out, okay, what I will do, sometimes we will have like a period where we talk to the family, to the carer, rather than without the presence of the patient. Okay, so we go, we talk to them. Okay, we explore more. Okay, you know, is there anything else that we can do to help them? Okay, now we are very small fraternity here in Malaysia. I will not be able to provide services to them. Okay, so what I will do, okay, I will suggest them to be involved in the group that have a similar problem with the family that they care for. Okay, so get into the group, go and talk and release yourself. Talk to everybody. Okay, by discussing, by talking, you kind of like reduce your stress. Okay, so that's number one. Number two, what I can do, if I can suggest to this family member or carer to get somebody else to look after the patient while they're taking a period, a moment for themselves. Okay, go and take a rest. Okay, so, and if this is not possible, what you can do, you can always, you know, sometimes take 1 hour or 2 hours for yourself. Okay, the patient doesn't have to be there. You don't have to be next to the patient 24/7. Okay, you done your part. Okay, you feed the patient, you wash the patient, you do all the things that you need to do, and after that, go for 1 hour, sit down. Okay, have a cup of tea, have a coffee, take a break. You need a break. We are human beings. We need a break. Okay, so, and then, you know, if they are like, you know, some people has a really spiritual belief, right? And some people has a religion. So, you know, sometimes by, you know, praying, they can relax themselves. Okay, they can channel all the stress. Okay, and then that's how they recuperate. They just relax, you know, for themselves. Okay, another thing is what I can do if the level of stress is like really, really high. Okay, and then it mixed with anxiety, with panic attack. Okay, this is when I actually refer them to our psychiatric colleagues. Okay, we have a psychiatric here. Okay, we have a psychologist here. So I refer to them so that now they can get a good help, a proper way. You know, through all this, there's so many therapies. You know, like, you know, Dr. Phelan mentioned just now, there's a cognitive behavioral therapy. It's not only for patients, sometimes it can be used for the carer as well, you know. So, and then, and anger management, panic management, and those kind of things. All this is non-pharmacological before they go into pharmacological treatment. If, you know, all the non-pharmacological treatment is failed. Yeah. So that I will do to help the carer. Okay? Maybe not much I can do because I'm in the center. We don't go out. Sometimes what I will do, we do have hospices who can provide psychological support to the patient as well the carer. So we send them, get them to talk to the carer, support them in any way that they can to help the carer. Okay. Am I answering your question, Puan Yayu?
Yes, Mr. Azizan. Is there any special preparation for the family? For example, the family need to care about patient pain, patient how to turn right turn left for patient, something like that. Is there any role for giving any short course, something like that,
Oh,
before
okay.
getting
Thank you.
his
Yeah.
patient at home?
Okay, thank you. Sorry, I missed that. But yep, this is about knowledge, okay, training of the carer. If they have more knowledge how to look after the patient, they know how to provide services, okay, that will indirectly reduce the stress because they know what to do, okay. So what we can do, sometimes we bring the patient to the hospital for a week, okay, and we get the carer learn from our nurses here, okay? So the nurses will teach the carer how to do this, okay? How to clean the patient, what is the best way of, changing the diapers, okay? And then how to feed the patient through the rice tube, through the PEG tube, okay? What to do, okay? And then we even teach them how to administer analgesia, okay? For example, family or the carer, right? If they have a very low knowledge about the opioid, the analgesia, they are so afraid of giving the analgesia, okay? So we educate them, okay? We tell them, okay, this is the regular one, okay? Every 4 hours, morphine, okay? And at the same time, we tell them, okay, if the patient is in pain in between, okay, give the breakthrough. Do not worry, okay? Don't worry. The main thing is to make sure the patient comfortable, okay? And then they will ask you, oh, what about if the patient becomes sleepy, drowsy? Yeah, it's okay to be sleepy, drowsy rather than shouting in pain, okay? But we will tell them the main thing is make sure that the breathing pattern is okay, okay? But most of the time when we send patient home, okay, we monitor the dose of the morphine, and we get the hospice to come over as well to check, make sure everything is, in the correct pathway, okay? And then, so that's how we educate the family. Now, another thing is, it's a bit, if the family doesn't have any experience regarding the disease, regarding the progression, they will have lots of anxiety. They will have a lots of panic attack. So what we do, we sit down with the patient, okay, with permission from the patient, together with the carer, we tell them what's going to happen. Okay, the progress, okay, now you have a liver cancer, okay, so what's next? Okay, your blood will become deranged, okay, we tend to have bruises and those kind of things. Okay, this is a disease progress. And then for what's next? You become delirious, okay, this is what we call encephalopathy. Okay, and what's next? You become sleepy, drowsy, you're not eating, you're not drinking. Okay, this is disease progress, okay. Okay, this will happen. Do not get panic. Okay, so we tell them, okay, until the end of the day, until the patient pass away. So we educate them step to step, A to Z. Okay, so they have all the knowledge, so they don't get panic. Okay, and at the same time, we provide them 24/7 tele helpline. We do have a tele helpline provided from the hospices, okay? Just in case, sometimes even though you have tell them, you have educate them, right? When it happened, they become panic, okay? So this is the line, call, talk to the person in charge, okay? And then the person in charge will, try to solve the problem on the phone. But if they cannot, okay, what we do, we go to the house and try to provide support or anything that we can provide. Okay, so that's what we do. Okay, so that's a good thing about, you know, the hospices, because they are there 24/7. There's people on call, and they will try to provide help in case of, you know, something that they don't know what to do. Okay, yeah. Okay, Puan?
Thank you very
Thank you.
much, Dr. Azizan. Bu Reni, may I
Yeah.
ask the same question? May I ask
To
same question to
Dr.
Mrs. Caroline?
Oh, okay. Please, please, Dr. Phelan.
Yes. Can you so I think one of the really important things is around the concept of providing people with first of all the knowledge as much as you can, but I think it's also important to express uncertainty. When you don't know that something is going to happen or you're not sure, you can say, this is usually what happens. And what you want to do is provide people with a sense that they're not alone, that they can call someone. Obviously, if you have the ability to do that, that they can go and find information. There is a lot of information online, and it's about how you manage that as well, ensuring that you're sending people to those websites that are trusted and useful and evidence-based. You will meet families who will come in and say, oh, look, I read something on Reddit or on Twitter, and you know, and so it's about creating that sense that you're with the family and you're with the patient on this journey. That doesn't mean that you know everything, and it doesn't mean that you're going to be predicting everything that happens, and that's okay. It's okay to express uncertainty as well as everything else. I think would be something I hope everybody can say.
Thank you so much, Dr.
Thank
Phelan.
you.
Maybe just sharing, because last paper that we produced in my lab, we focused on the decreasing the disease severity for the chronic pain for patient with fibromyalgia. So we increase the pain catastrophizing and also pain self-efficacy. I think it will also help to decrease the disease severity of people with the palliative condition. And now we also doing the project about the PNE, Dr. Phelan, the pain neurological education to promote the condition or the disease severity also for the fibromyalgia patient is a part of the, I think, palliative caring for the patient.
Yeah, that's
Thank
great.
you so much. Yes. And we have one question to Dr. Phelan from our student from the nursing department. As Dr. Phelan mentioned that the pain can cause several conditions like a depression, anxiety, and anger. And how we can turn this negative feeling into the positive one when it's occur. Is it possible or impossible? Thank you.
That's a great question. Look, I think there are some things that we need to remember. In palliative and end-of-life care, there are more than one reason for somebody to feel sad or depressed. And we need to acknowledge that. And people can be very angry, particularly when, and we see anger in young adults, particularly, or and it's really about providing people what we call space to express their feelings is incredibly important. And not diminishing those experiences by sort of saying, you know, those platitudes of, oh, they're there, everything's going to be okay. You know, these people are facing the end of their life. I think what we try and do most is allow that expression and then try and work through the goals of care and through that person's sense of purpose and and optimize their function towards the end of life. What we try and do, particularly with people who are very depressed, and depending on the prognosis, so depending on how long they have to live, medication might be an option. It often isn't in palliative and end of life. Antidepressants take much longer to work than some people have to live. But what we can try and do, and one of the things we can anchor on is small steps at a time. Set small achievable goals. Sometimes just sitting in a chair for a few hours is a great goal to start with. We have programs here in Australia where we create or grant final wishes. And that's something that's very common. There's the ambulance services around Australia will take people to places, to the beach and things like that, to the football, so they can have that experience. In Canada, there is the 3 Wish Foundation in intensive care for people who are at the end of their life. So that how would you like to spend your time is a really important question to ask people. And that can shift a conversation away from I'm angry that I'm dying to I have time to do something that I really want to do before I die. So that's how I guess we would really approach that.
Thank you so much. Thank you so much. And maybe we have another question to Dr. Zakaria. The question is like how to overcome to the discrimination faced by HIV patient in accessing palliative care. Maybe what advice that professor have for the HIV patient and their families who want to seek the further information about the palliative care? I think it's especially for the HIV patient, Professor, because it's we know in Indonesia we have some kind of a little bit discrimination for these patients. I'm so sorry, Professor Zakaria. Maybe you can open the
Oh, sorry.
speaker.
Yeah. Can you
Okay.
hear me? Yeah, you can hear me. Okay.
Yes.
Yeah. So this is for patients who have HIV/AIDS, right? Okay. Again, patient confidentiality is very important. Patient privacy is very important. And we do have patient who doesn't want family member to know that they have HIV, they have AIDS, okay? And we respected the wishes, okay? So in terms of for this patient, right? For us, the access is here, it's there, okay? So we provide them with the education, with all the information, okay? And if they want, they can come and talk to us, okay? So we promote, what we do, we promote palliative care. We advocate palliative care, okay? We tell everybody there is a palliative care, okay? And then we provide them with the line, okay? With the email, okay? And then if they don't want to be, they don't want people to know that they have HIV and those kind of things, so they can just come straight to us, okay? Now, even sometimes, okay, if they don't want their name to be used, okay, we will provide them with a special identification, okay? So they will be known as this number, okay? So, and then we will provide them whatever they want, like I said, according to their own values. What do they really want, okay? So this is the goal of care. Okay, and then we help them according to their own goal of care. So that's how we provide, for those people who doesn't want to be known to the rest of the community. So again, here, patient confidentiality is very important, okay? And whatever we do is according to patient goal of care.
Thank you very much, Professor. We have one more question to Professor Manit. One of our participant interesting about the transdermal patch for the palliative care, Professor. So maybe may I ask the effective of the use of the transdermal patch compared to the oral medication, and how is the patient way related to the dose of the transdermal patch. Maybe can you share more information about the transdermal patch for this palliative care?
Okay. So the first thing I will give you is about the benefit of the transdermal pad. Is the transdermal pad is the one of the drug delivery system is very useful in some circumstance of the patient, because that is provide the long-acting efficacy for 72 hours by the after the patch applied. It's very easy for the patient, better than you take the medicine, because sometimes the patient forgot to take the medicine and the patient have the pain symptoms or uncontrolled pain. And the second thing is some patients have the problem to take the oral medication. For example, for me, I have the patient who have the esophageal cancer or head and neck cancer. It's very hard to swallow the drugs. So the transdermal patch should be the better way to the patient can get the drugs without do not need to get by the oral intake for the medications. But the thing is the another question from you already mentioned is the using the transdermal patch. Is the weight related dose or not? The transdermal patch before we use the transdermal patch, most of the times we need to know the morphine dose that the patient require per day, and we convert them to the transdermal patch dose. And this is not, we not usually use the patient body weight to calculate it, transdermal patch dose, because that for the small patch is quite provide the equivalence morphine dose is very high. It's for 60 milligram morphine oral dose is calculated to be 25 microgram of transdermal patch. And some hospitals do not have the patch less than 25 micrograms. So that means one patch is about 60 milligram of morphine per day oral dose. Is very high. So we most of the time we start with the morphine, and we want to know how the dose of morphine per day the patient require and convert them to the transdermal patch. We don't calculate from the patient body weight.
Thank you very much for the answer. Actually, we have another question, but maybe because the time limitation, maybe we will share this question into the speaker's email, and I hope all you are willing to answer all the questions. And thank you so much to all the audience for the active participation and engagement in today's plenary session. We have had the privilege of hearing from some of the leading experts, Dr. Caroline Phelan, Dr. Nur Azizan Zakaria, and Professor Manit Setio, who have shared the valuable insight into pain management approaches in palliative care. We also discussed so many innovative approaches and explore the future of our field, equipping us with new ideas for the new research, for the new condition and perspective that we can take back to our field and the community. Thank you also all the professor. And okay, and I'm going to after this discussion session, for now we will be taking a short break. And thank you so much, Dr. Phelan, Dr. Zakaria, and Professor Manit. I'm looking forward for the personal meeting with you, maybe in the next occasion. Okay, now I'm going to give the frame into our Master of Ceremony. Thank you so much, and see you for the next event.
Thank you.
Thank
Thank
you.
you.
Please still stay with us. We will have another session, Professor. Thank you. Mbak MC,
Thank you to
silakan.
Mrs. Reni Wan Abdullasari, who has guided the presentation and discussion. The next agenda is the certificate submission. We have had the pleasure of listening our distinguished speaker, who has shared with us their insight and expertise on a very important topic. We are very grateful for their time and generosity. As a token of our appreciation, we would like to present them with a certificate of recognition for their valuable contribution to this event. Here is your certificate to Dr. Manisiu. And then this is the certificate for Dr. Nur Azizan bin Zakaria.
Thank you.
And the last is certificate for Dr. Caroline Phelan.
Thank you.
You are welcome. Ladies and gentlemen, we have reached the end of agenda. Let us close this event with reciting Hamdalah together. Alhamdulillah, Rabbil Alamin. I hope you have enjoyed the stimulating presentation, insightful discussion, and fruitful collaboration that took place over the day. I am Laili, as the Master of Ceremony, would like to thank all the speakers, sponsors, organizers, and participants for making this event a success. I wish you all a safe journey back home and look forward to seeing you again in the next edition of this conference. Please forgive me if you found a lot of mistakes. Thanks for your attention. The last I say, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you,
Mas Dr.
Dr.
Zakaria.
Caroline,
Thank
Thank
you.
Dr.
you, Prof.
Aziza,
Thank you, Dr. Azizan. Thank you, Dr. Farali.
Prof. Manit. Thank you very much. Bu Reni, thank you, Bu Reni.
Thank you, moderator.
Thank you so much.
Dr. Farali.
Sama-sama.
For this